Hi, I'm Jens Chapman, and welcome to the Seattle Science Foundation. We thank you for your interest over the past years in our regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves on offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass.
And we're live in 5,
4, 3, 2,
1.
Welcome, everyone, to Neurology Grand Rounds. We're so fortunate to have Dr. Aleksandra Pikula, who is quadruple board certified in internal medicine neurology, vascular neurology, and lifestyle medicine. She completed her neurology and vascular neurology fellowship and postdoctoral training at Boston University, Harvard University, and worked on the Framingham Heart Study while being supported by the NINDS Institutional Grant and National Clinical Research Award from the American Heart Association. Dr. Pikula is the inaugural J. Ansari Sunshine Chair in Stroke Prevention and Cerebrovascular Brain Health at the University of Toronto and the University Health Network Krembil Brain Institute, where she also serves as director of the J.S. Sunshine Center. Dr. Pikula is also a vascular neurologist, an associate professor of medicine and neurology, and co-director of the Women's Neurology Program at U of T, as well as a clinical investigator at the Krembil Brain Institute. Her clinical and research focus lies in stroke prevention and outcomes, with a particular emphasis on patient-reported outcomes in women and younger adults with stroke. She's locally and globally involved in implementation science of innovative models of care for population with lived experience. She advocates a holistic approach to brain care, specifically targeting stroke and dementia prevention during midlife through evidence-based lifestyle medicine pillars. Welcome, Dr. Pikula. Thank you for coming and giving your grand rounds. We're very excited to have you. And she's going to talk to us today about empowering women, closing knowledge gaps, and advancing stroke prevention through patient engagement. Thank you again.
Thank you, Nancy, for the kind introduction, and thanks for everyone who was able to join. I know it's early morning in Seattle. Here it's already 10:30, so we had few things already happen. So let me just share my slide before I start. Okay, I hope you can see my slides. Okay, so let me just minimize this a little bit. Again, thanks much for this invite. It's really my pleasure to be here and to talk about empowering women. Really the focus of this talk is to illustrate how we need to close the knowledge gaps in order to advance stroke prevention through patient engagement. And patient engagement is really a new and novel approach to essentially co-design the care. And we're doing a lot of work in Canada, at least, and specifically here in Toronto around that. And I'll try to illustrate that this morning. So let me just make sure my slides are advancing. Okay, so a couple of disclosures. Obviously, most of this is for the research we're doing, and we have sort of exciting collaboration with university as well as with granting agencies and philanthropy that established this work that I'll be presenting today at the Sunshine Center. But, you know, instead of, you know, putting this slide at the end to thank my team for this amazing work we're doing, I really want to say that none of this can be done without really a lot of people and community research in brain care, stroke prevention, and in general, through patient engagement programs cannot happen without philanthropy support that we have. And this specific program that I'm leading now it had been established in 2023. And really the idea around this was to centralize the voice for stroke patients and caregivers community, as well as population here in Toronto and beyond, and sort of set an example how to encourage trust and engagement from patients, caregivers, public, to help us co-design new models of care in preventive and women's neurology. We're fortunate enough to have funding for next 10 years. So I'll be really sharing the preliminary ideas and work that we have done, really to illustrate and hopefully to spark some interest for some of you in the audience to perhaps do similar work in your space, because the stroke prevention and preventive neurology is something that the whole world needs. And I'll talk about, the whys and how women's health, pivots that through the sustainable approach to education, as well of, up and coming graduate students, as well as clinical fellows and researchers. So in Canada, we make always statements of acknowledgement of traditional land, and I'll do one for University of Toronto, which essentially I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississauga of the Credit. And today, where I sit, this meeting place is still the home to many Indigenous people from across Turtle Island, and I'm grateful to have the opportunity to work on this land as a settler from Croatia. So the learning objectives of my talk is a storytelling, and stories are what makes our condition human. And this comes from a patient of mine who is very much engaged in the work we do. But I'll try to illustrate why it matters in clinical space where we practice every day. And I'll review a little bit of how the forecasting of global burden of stroke, and specifically stroke in women, looks like. I'll illustrate that through a couple of stroke clinical cases to just bring us to the space where we work every day. We'll talk about the importance of stroke outcomes in young adults and women, and really illustrate the patient engagement as a new concept for stroke prevention and optimal brain care, making a couple of conclusions and hopefully having time for a rich discussion on this particular topic. It's needless to say that the projected global trends of stroke and all age-related neurological conditions, specifically dementia, are essentially really leading causes of disability, adjusted life years, and this number is only climbing up in the last 10 years. With stroke being the major contributor, simply because we have fantastic acute care now in mostly in highly developed countries, where actually we decrease the mortality rate, but we increase the disability rate. About every other person in the world has some type of neurological condition, and more than 50% of those people are women. So it really does matter for more than half of population to understand, some sort of differences and disparities that we hopefully can tap on when developing the preventive strategies. More importantly, over the past 30 years, there is a massive increase in incidence, specifically in middle and low-income countries, by 70% for stroke, and mostly due to, obviously, risk factors such as hypertension, obesity, and many others. And more frightening is that over the past 10 years, the increased incidence and prevalence among younger populations, specifically working population, which is by public health defined as less than 65 years of age, there is a really dramatic increase of stroke incidence, and more so among those that are younger than 50 years of age. And why is that it's probably due to lifestyle, risk factors, as well as increase in prevalence of sedentary life, but also due to a massive increase in prevalence of hypertension. So stroke is not anymore a disease of the elderly, but rather a disease of the midlife or perhaps younger adult age. And the projections and forecasting of the burden of cardiovascular disease, specifically stroke, in the United States through 2050, that was really nicely summarized through the available current data with a presidential advisory paper last year, shows that all cardiovascular conditions, including stroke, are gonna go up in terms of the prevalence. But more importantly, all risk factors such as hypertension and obesity and diabetes are also going up, as well as unhealthy behaviors such as poor diet, inadequate physical activity, and sleep. And when you deep dive into this paper, you also see that the forecast looks quite detrimental to women. The prevalence of CVD and stroke is expected to go up among women. And it's driven by age, it's also driven by lifestyle-related risk factors, specifically for women during midlife, when there are conditions such as hypertension, diabetes, obesity that are driven by essentially change in hormonal status, are projected to rise. But this is even more obvious for certain racial and ethnic groups. And there is obviously massive health disparities when we talk about underrepresented communities, where we talk about systemic health inequities. And it's really important, like it or not, that we address this moving forward. So it's not really the risk factors, but it's also biological and genetic factors, but more so social factors when we talk about access to care, providing, trusted healthcare system without historical exclusions when we're talking about primary prevention of stroke or even secondary prevention of stroke, specifically for women. So we are very versed in traditional risk factors, and treating those, and we have fantastic tools, specifically pharmacotherapeutics. But we keep forgetting that there are women-specific risk factors throughout the lifespan, during the childbearing age, as well as pregnancy, and then also during menopausal transitions, where those risks are much higher and sometimes simply neglected by clinical protocols. It's also important to understand that stroke outcomes in women are less favorable than in men. Specifically, women have higher mortality, lower functional recovery rates, lower quality of life, more post-stroke depression, as well as more post-stroke cognitive impairment. And coming to what we do, it's also important to understand and recognize that medical community education and awareness also contributes to it. There is under-recognition and under-screening by providers, even though we have pretty well-established guidelines, but there is a lack of implementation of those guidelines and assessment of early risks. And that could be simply because we lack female-specific risk factors, risk score tools that one can use in the clinic. But yet, I think integration of these guidelines is something that we should work in the future more strongly. When we talk about public or patient community awareness and knowledge, we also know that there is low health literacy among women, as well as general public about women's stroke risk or stroke signs across the board. Any country that published on this reports that women don't know stroke risk factors as we would expect them to know. And more importantly, even after experiencing the stroke, post-stroke education is very slim and under-supported. There are really no studies that indicates anything that is specifically geared towards women in terms of education on various issues that are specific to their recovery and stroke prevention after the first event. So really the scope of the problem is under syndrome that we call it here in Canada, and we developed a nice document in 2018, which is called Misunderstood, and the link is in the slide, and I'm happy to share it. It's really to emphasize how women in the space of cerebrovascular and cardiovascular world are underinformed, underinvestigated, underdiagnosed, undertreated, underrepresented, and undersupported after the event that they experienced. So there's some work that we need to do. The question is, how do we do it? So now I'll bring you to the space where we practice, where we see our patients and talk about stroke outcomes in real life. And we'll talk about good outcomes. So I'll illustrate 4 distinct stroke stories. Here is the first one. 88-year-old female comes to hospital. She's at the baseline functional and has pretty moderate to severe right MCA syndrome. She's treated with EVT, recovers, discharged to high-intensity rehab, and comes to my clinic at 90 days when we usually assess our metrics of good outcomes or bad outcomes by MRS and NIH. And she has MRS of 2. Her NIH is 6. She has a good support, feels well. She lives alone, but tells me I have a good social life. So he's thriving. The second case is 76-year-old male. He is retired, comes with a good baseline with a moderate-sized stroke, proximal M2 occlusion, given TPA at the time when we use TPA, improves to NIH of 7, discharged to high-intensity rehab, goes home. At 90 days again, comes to see me. He recovers with the same outcomes based on the numbers that we have on MRS and NIH, MRS of 2, NIH of 6. He lives with his wife, has good support, he's happy to be alive and enjoys his grandchildren. Third case is 40-year-old female. She's professional, good at baseline, comes with massive stroke, left MCA occlusion, successful EVT, recovers to NIH of 4, discharged to high-intensity rehab, goes home, and at 90 days, her MRS is even better than first 2 patient of 1, NIH 3. She has a good support. She's unable to go back to work. She lives with husband and kids who are teens, and also taking care of elderly parents. And she asked me to remind her why I think she did well. So the narrative is already changing. Then we have 54-year-old male, professional, again, good baseline, comes with NIH of 18, right MCA occlusion, successful EVT, recovers again to go to high-intensity rehab, goes home, comes to see me at 90 days, MRS of 1, NIH of 3, good support, lives with his wife. His kids are a little bit more older. They're already gone from home. He's back to work part-time and tells me I'm doing okay. So all these 4 cases are discharged from my clinic just by default. They go back to primary care physician, and they will have a sort of a green light to essentially graduate from stroke clinic with follow-up on risk factors with their distinct MD. But if I put these pictures or photographies of these people, and if we deep dive in the social determinants of health, maybe, you know, the story and our outlook of these patients will look like a little bit different, but we don't know because there is not much data about specifically young stroke population to understand the outcomes long-term or after 90 days, because our metrics that are very objective are really related to immediate outcome, which are measured by the success of our interventions, but not really by the quality of life that they will achieve after that intervention. So when we talk about young adults, sorry, so there is not enough data or literature to guide us on how to design the interventions long term for this population. And we have this initiative that we established in 2018, 2019. It's essentially involving 32 cohorts in 29 countries, and 2 are coming from Canada, and a couple of from United States as well, specifically from Stephen Kittner. And the specific questions are asked about risk factors, causes of stroke, functional outcomes, long-term outcomes, and recurrences. And we're assessing the geographic differences and across the WHO regions, but the data is not yet available. What we do know from a couple of studies is that young adults with stroke, specifically those under 50, have good recovery. About 60 to 80% of patients will achieve good recovery with MRS of less than 2. 60% of those do not require rehab, so they're really missing the usual stroke transition of care pathways. And of all, about 50 or more than 50, depending on the paper you read and the population that's studied, do not return to work despite good recovery. So obviously, we're missing something in stroke recovery literature. The first analysis from the GOLD project, which is essentially all our retrospective data on 17,000 patients, we also see that there is a higher mortality in low and medium income countries, and there is a pretty big disparities existing despite younger age, and there is some disparity in gender as well, yet not published, but they also have fewer vascular risk factors. But again, we're not gaining much of a knowledge around the recovery or outcome data. What we do know from future study, which is a study from the Netherlands, which is a prospective study on, I believe, 700, 800 patients follow-up for more than 20 years, that the recurrency is very high, about up to 15% at 10 years follow-up, and up to 45%. So almost every other person will have a recurrence of the stroke or any CVD within 25 years. So obviously, not only that we don't know about the long-term outcomes in terms of the recovery, but we also see that the risk of recurrent stroke is much higher given the longer lifespan of this population. So obviously, there is a need for better stroke prevention strategies for this particular population that does miss usual stroke transition of care pathway. However, there is no reports on sex and gender specifics really to kind of gear the development of the interventions a little bit more specifically. So the current stroke prevention clinic model simply does not work for young population because many of them don't go to rehab. And even if they go, they graduate from stroke clinic back to PCP and family medicine that essentially are not equipped to really support them for their needs that are mostly around the quality of life. And so what happens in the quality of life or health-related quality of life outcomes in young adults literature? So there is not enough. There is some emerging literature, specifically from Australia and us. But what we know is that despite good outcomes, 20 to 30% of this population still faces psychosocial challenges. They have pretty high prevalence of depression, anxiety, fatigue, as well as severe fear of recurrency. And that significantly reduces quality of life. And obviously, there are no economic analysis how that translates into the, money value. But we also know that social factors do impact those quality of life outcomes, specifically return to work and social support at home and in the community. It's important to emphasize also when you read the quality of life literature that among young adults with neurological conditions, this is measured by quality in leisure activities, interactions, and personal life, whereas the quality of life among older adults is measured by ability to walk and speak. And if we go back to our first 4 cases, and I mean, obviously I painted them to give this story that can illustrate the findings from the literature, it's important to understand that there is a difference in needs, even in quality of life, not only in functional activities or recovery. Sorry. So again, there is no robust reports on sex and gender specifics. Actually, very few reports are even, dichotomizing based on sex or gender data. So there is a massive knowledge gap when we talk about stroke outcomes. What we measure in acute care have no meaning to our patients in chronic care model. And, even when they do well, and that does not translate into a meaningful recovery for younger population. And, being alive, being able to walk and talk, it's simply not something that we can consider as a good outcome long-term, even though, in all metrics, obviously we do. So that brings me to what we talk about a little bit more often than not lately, especially in neurology space, but also in a stroke medicine space. It's patient-reported outcome measures and patient-reported experience measures. So really, those are novel tools in stroke research where we talk about health-related outcomes. And specifically at Sunshine Center, we're evaluating that in the context of sex and gender disparities, really to be informed how to design the next step in terms of the interventions. And if possibly, that should be also culturally sensible. But again, there is no robust reports on sex and gender specifics in stroke. And what it means to assess the patient-reported outcomes. It's essentially health information that's collected directly from stroke patient as a measure of not only functional status, but well-being, quality of life, symptom burden, patient experience of care, satisfaction with the trajectory and the journey through their healthcare story, as well as health behaviors, how to optimize their lifestyle prevention or taking ownership in terms of preventing the next detrimental event such as stroke. This is hard to study. This is hard to collect. Obviously, we need a lot of manpower and women power to do so. But it's very important because, prescribing the pharmacotherapeutics is simply not good enough. It's good start. We have a lot of data around, stroke prevention in primary prevention and secondary prevention space with aspirin, statins, combination of many pharmacotherapeutics, but the behavior and, the quality of life is a piece that affects the next step in terms of the prevention and behavior of the person that will engage with the healthcare system to do something about the prevention. So really what we're missing when we talk about elevated stroke risk is population health literacy, but also provider health literacy. So that brings me now to what we do at Sunshine. So this is essentially really an illustration of what we're doing, really to simplify, because the work is quite complex and very dynamic, very iterative, very fluid. But what we're doing, it's essentially a life after stroke research. This is almost replication from oncology, diabetes, and cardiology world, where we're doing a rapid translation and implementation of iterative development of implementation science through the lens of patients with lived experience. So what we're doing, we're designing studies that are not longer than one and a half year. Through the mixed methodology, we explore the quantitative needs, and then we deep dive through the qualitative methodology, really to assess the post-stroke needs in terms of care, preferences in terms of care, knowledge around what stroke prevention means, their current habits, as well as how where they live in their environments can support that and facilitate, or what are the barriers. and what are the motivators and motivation to maintain, what they are told in the clinic space for stroke prevention. And based on that, essentially, we're co-designing new models of care that actually, in fact, we're already testing through the developmental evaluations and knowledge translation. So the iteration of this process is essentially all the knowledge that goes back to be evolved through the developmental evaluation with the patients during the next cohort that comes to essentially spend time with us in the new model of care, which is at this point really the coaching and program education on shared medical appointments that you are doing at your center already. But however, we want actually to engage patients to a point where they can be trained to deliver this kind of a model in the community. So it's very complex, but it's supported by government for next 5 years. And we're hopeful that this will enhance economically also the preventive neurology space, where we need more robust prevention strategies for the community. Everything that we do for women's brain health as well. We are exploring the same needs, knows, hows, and do's to essentially really educate women about stroke prevention and brain health. The reason we're doing this perhaps more successfully than others, and then I'll illustrate a few examples of the specific projects, is we have robust support from the Pride in Patient Engagement in Research Institute here at University Health Networks. It's a huge institute that actually developed the whole framework how to engage patients in research at different steps of the intervention you're developing or any research you're doing. And it's really interaction through decision-making, what's needed to inform the process. The patient serves as a consultant. They are involved in the protocols. They collaborate, they empower us, and they innovate. But they also can come in the volunteer position, but they also can come as a paid full-time position person in the space of the research. And the idea was really to assess, the needs. And the question is very simple: what do my patient need? So, for example, through the mixed methods, we examined the needs around stroke prevention and learned that people are really lacking education about stroke, and they're not happy with the care delivery. Because it's one-on-one here in a stroke prevention clinic. When they see one provider who tells them that they have good numbers, they are on good medication, off you go. And that's not motivational at all to do any change in the behavior. Women specifically prefer on-demand and in-person support. They're focused on self-management, and they like to gather in the groups. When we assess the knowledge around the Essential Lives 8 or Life Essentials 8, we learned that women do have a lot of knowledge, but they don't apply, and then we dig into why. So let me illustrate how we did this, and we published a lot on this. We got a lot of funding to continue this work, and there are many papers coming through the pipe. The first study that was funded by CIHR as a priority funding was on a young stroke needs study. What we wanted to do here is, knowing that these people are kind of in the limbo if they don't go to the rehab, we wanted to evaluate the physical, psychological, and occupational functioning of these patients. We used the NeuroQOL, which was validated tool by NIH, specifically for neurological patients. And we assess also their post-stroke care preferences using what I mentioned, patient-reported outcomes, focusing on gender differences. The study was divided into, as any of our studies, in two parts: quantitative, which was essentially surveys that are validated on the basis of what we assessed, specifically around the occupational questionnaires, as well as quality of life through physical, psychological, and social domains. And even though it looks small, 85 young adult stroke patients, it's a huge number. Most of the studies are up to 15 or 20 patients, mainly from Australia and some from Europe. And we really wanted to assess the needs after 90 days post-stroke, when they complete all the required sort of post-stroke government or insurance-supported care. We recruited over one and a half year, as many as we could. So the quantitative part of the cohort, which is those 85, consisted of about 42% of women, mean age 48, NIH 3, so very mild strokes, MoCA 28, and most of the patients were at the mean of almost 1 year after stroke. So interestingly, 60% of those with mild stroke, as you can see, young, and year after stroke, did not return to work. So really sort of compatible with the data from the literature. But again, when you looked into quality of life, we also saw that most of them had impairments with social activity, social engagement, anxiety, sorry, and some cognitive function based on subjective measurements. What we have seen that other studies never explored, that women had worse physical and emotional health. They also looked for more preference in terms of physical health, looking for support and self-management, lifestyle, behavioral changes to support that lifestyle changes. Support around self-identity and return to work, really to be able to conceptualize and accept that the work they're doing might not be their best next step, but they might look for a new location. And what was interesting, the therapy preference for psychosocial symptoms. Women preferred holistic approach, where men really looked for pharmacotherapies and quick fix. And implications of this really study, even though it looks quite small, is that we just reiterated that there are complex challenges after stroke for young adults. They're massively beyond physical recovery, because those are mild strokes, and mostly they're psychosocially impaired, and they have occupational disruptions that do impact their professional and personal life. So this is sort of really a complex table, but I'll take you through. So those are all themes and all outcomes that we collected. And under number one, the effects of stroke kind of resembled almost lifestyle medicine pillars and needs that emerged from the patient-reported outcomes. So they asked for it. We did not impose that on them. So unmet needs really met educational needs around that lifestyle strategies. Whereas under number two, there is obviously a lot of gaps in terms of experience with healthcare for young stroke population, with rehab and or no access to rehab through positive and negative experience, but also experience with healthcare as a whole. And I'll illustrate that a little bit further. So the second step of this study was to explore those unmet needs a little bit more deeper. So we invited everyone to participate in individual interviews, and 22 participants agreed to pursue that second step. And this was very iterative and very exhausting process for the research team, but we collected massive amount of data to understand that unmet psychosocial needs. If we want to design any intervention, we have to understand that those needs are evolving longitudinally or through the journey of the stroke recovery. They have different needs in acute setting, subacute, and during the chronic phase of recovery. And those needs go around, financial and role transition, as well as negative experience through the rehab, as well as a long-standing need for self-advocacy and age-related opportunities for recovery. So then we said, because we now understand that actually everything is mostly around education. So let's tap first on that. And then we got another grant to explore, really the understanding around what they know about brain health and what stroke prevention means. And honestly, I have to say, studying the obvious things, it's really hard. This is not new medication that I'm randomizing people, into, placebo or something that will be as effective as EVT, but it's very important for the quality of life and stroke prevention. And we said, okay, let's do just basics. Just let's assess, Life Essentials 8, how much do they know about that? Because these are people that we educated on stroke prevention. These are stroke patients in high-risk population, so they should know a lot. And let's also kind of check, what do they do? I mean, even if they know. And then at the end, really, how do they see the intervention in our space where we practice as a clinician could look like? So we enrolled about, again, over 1 year, 100 patients, approached 240 and 100 kind of accepted. It was exhausting, sort of a survey approach through a quantitative phase where we assessed the lifestyle medicine related knowledge, behavior facilitators and barriers, and what helps them adopt the healthy habits in addition to assessing the medication compliance and many other clinical things. And then we said, okay, well, once we learn that, let's again design the qualitative phase and go deep and dive into mixed gender participants' needs as well as women only. And that's the part where we explore the views, perspectives, what they like, what they don't like, how we can integrate this in our current clinical practice, and, how we can propose this to the guidelines boards to essentially integrate into standard recommendations for certain parts of these diseases. So what we have done here, we enrolled about 54 patients with prior stroke. The rest were people with other neurological diseases, and those are people that visit the stroke prevention and neurovascular clinics. So they're either TIAs or they're AVMs, or they're people that had subarachnoid hemorrhage in the past. But with ischemic or hemorrhagic stroke, we had 54% of patients, half and half male, female. And as you can see, we had one non-binary person, and then we dichotomized less than or more than 45, again, roughly equal distribution. And what we have seen that even after, these people went through the stroke prevention education process, either by their provider or by our team, which we have here in the clinic, a lot of patients did not know what are the recommendations about physical activity, dietary intake and recommendations, or perhaps sodium intake and those recommendations. So it was kind of disheartening to really see that after you educate the population that went through a pretty dramatic event, even though they have mild NIH stroke scale at the entry of the study, they're still not well equipped in terms of the knowledge. More disheartening was actually that in terms of the nutrition, roughly 70% of population ate still processed food on most of the days. Even though they did not have major disabilities, only 36% engaged in moderate physical activity. Still about more than 50% slept less than 7 hours a night, and about 63% reported moderate high level of stress. So all the risks that we know are modifiable risk factors for stroke that we can definitely tackle, but we don't have a simple medication for. So we have to pull our sleeves and really find out how we can engage this into our standard models of care for stroke prevention. More importantly, when we look based on knowledge, on age, those that are younger than 45, even though they had higher knowledge around serving recommendations and the nutritional as well as women, they simply still rely more on high consumption of processed food, women specifically, and women had quite unhealthy relationship with food through their emotional eating. And then this is kind of a summary of what I've just said, because there is a lot to digest, but in general, we could summarize that, knowing doesn't mean doing it. And if you're not doing it, we have to explore what are the barriers and how we can engage that in the next step. So what we have done then, we deep dive into qualitative results, and this is really sort of an awakening moment for us. What the average clinician doesn't have time, we have done and summarized it here. It's that, and I'm just showing you women's only focus group findings. We have over 20 interviews until saturation happened with the teams. But themes are really around, lifestyle habits, health challenges after the stroke. Parenting was the big one, not being able to parent as before. Professional needs, having to be, having to leave the profession and pressure to return to the same, sort of kind of torn in between. Social expectations of women that had a good recovery in terms of physical recovery, but still not able to, function well. And then psychosocial safety and healthcare system, teams were pretty robust in terms of misdiagnosing and huge administrative burden to receive disabilities. So we draw on 7 key findings, and this is all designed by women that participated in this research. So they essentially created recommendations for our program, and they made recommendations around creating programs that are led by and for women. And it's really creating the safe space where they can talk about things that they usually don't with their providers, offer mental health and emotional support, make sure that there is a peer support group that is integrated in those visits, give families and patients easy to understand health information, and make stroke care more personal and easy to navigate for all those that had a good outcome. And so they made also recommendations at the meso level and macro level, and we're working with the care holders and also Heart and Stroke Foundation Canada on this, and how to integrate it into more robust community healthcare centers. But what really emerged from those studies is 2 new models, one for care, which we now are testing. It's a Splendor Care model that's mostly emerged from mixed gender studies, and new model of education, which is new educational toolkit to support young adult women's parental role, professional responsibilities and goals in terms of self-care post-stroke. And this is really fantastic tool that is gaining a lot of traction now. But Splendor Care model is something that we got funding for next 3 years to exercise the share medical appointments for management of hypertension through patient engagement. and peer-led sessions, and it's very heavy on economic analysis to essentially try to integrate that into our model of care for the Ministry of Health. And then the second was that educational toolkit that we co-developed and co-designed with patients' participation. And it was essentially a collaboration through what, again, was mixed methods to essentially develop a very robust tool with 40 women with lived experience that were meeting over 6 months with essentially a scientific associate who led this whole project. And then we tested it through different phases based on established protocol on co-designing the educational toolkits for patients. And now we're in the final dissemination phase where we have essentially Life 2.0 learning toolkit that has 5 main modules, and we're just adding the menopause module to support young adult women post-stroke to really be equipped to self-care and support other women in the community through the development of peer support programs. This is really gaining a lot of attention, and we're going to be translating. This is 100 pages content with very illustrative approach to specific themes that women came up. And more importantly, a lot of is geared towards female and sex-specific risk factors for stroke through the lifespan. Another very important thing is that we're going to be developing web-based platform where they'll be able to take this as a course and gain the certificates to essentially kind of graduate with the knowledge from stroke care. But what we need moving forward is really sort of more robust education for population, and we're building a few other collaborative projects through massive online open courses and digital twin technology with a couple of companies that are interested to support us, and really want to close with massive need for stroke in women education for providers. As Nancy mentioned at the beginning, we have women's neurology program here, very robust women's neurology fellowship for last 5-6 years, where we trained about 40 elective residents nationally, internationally, who come for 4 weeks to spend time in our distinct women's neurology clinics. We have stroke in women, epilepsy in women, MS and headache, and they also gain experience through the high-risk pregnancy and obstetrical neurology clinics. So really we need to inform our neurology trainees about importance of women's issues in neurology. And we also published recently in a curriculum that's well received, and now we have the whole educational platform with ANA, which is called Insight Network, providing education on specific topics that are relevant to women's neurology. So really education for providers is important, not only in stroke, but in general in neurology. And obviously training in research and knowledge translation is very important. So I'll conclude my talk that stories are what make our patients' conditions human. Global burden of stroke and all other age-related neurological conditions are going up, and there is emergent need to do something about it. And we need to focus on structural and social determinants of health, long-term outcomes. No one else will do that. Primary care physicians are not equipped to take care of this. And more importantly, we have to design and collaborate with our patients really to offload that from us and hopefully can help us to improve stroke prevention and brain care models of care, and essentially take that to the community in a more robust way. So I'll stop here because I know we have a few minutes left and open for questions. And again, thanks, Nancy, for inviting me, and thank you all for listening.
Thank you so much, Aleksandra, for that outstanding talk on your innovative research in implementation science, which, as you say, is really challenging. And you're literally transforming care. So are there any questions from the audience?
And that's okay.
You covered so much ground. I have a question. I mean, you know, you spoke about pharmacotherapy and how in some ways that's easier to implement, but I would argue, frankly, that we're under-treating women in midlife with pharmacotherapy for primary prevention, given the shifts in their cardiometabolic burden through the menopause transition. Do you want to comment on that?
Yes. Oh, no, I totally agree. I mean, you know, what the work we're doing, it's really kind of a secondary prevention space. And that's where, you know, you would believe that, you know, we're doing well there. Although, you know, there is still the adherence to medication post-stroke in stroke population. And we don't know how that looks like for women. It's about 65%. So obviously there is under treatment there, but it's more under surveillance, I would say. We don't know. But I totally agree. First of all, I think screening is miserable during midlife, and under treatment is obvious during midlife for women. And I think we're just kind of really entering that space where we're a little bit more open talking about this, and enhancing the needs around the midlife and menopausal transition, where, you know, the stroke doubles actually for women during that time compared to men of the same age. And there is obvious reason why that happens. So, and I'm hopeful that we'll have more years and more guidelines on how to do that. But I agree with you that that should be done better.
Thank you.
You're welcome.
Okay, let me take a look in the chat.
Mm-hmm.
I just see that there's a comments there, but yes,
Thank you. Well, I know. I mean, talking about obvious things, it's hard, you know. We're not accustomed to do that, and you know, but this is what matters to patients, and we have to attend to it.
Absolutely. And I mean, I think talking about how to implement, this care transformation, which you're doing in such a radical way in Canada, with different, of course, support structures as well. But it's really impressive.
Thank you. It's small steps, I guess. You know, sharing and talking, I think it can move the mountains. So we'll see. I'll continue doing this passionately on behalf of patients, but I think they can help us a lot. I think that's the space that we did not tap enough. Patients, advocates, patient engagement groups, you know, patients with lived experience. If you bring them really on board to your clinic, they can do a lot, because you know, that peer support and interaction with between the patient is much more profound and sustainable than between the provider and the patient.
Yes.
They'll not take our job away, you know. It's more of
No, but
collaborating. Yes.
I think what you're pointing towards, which resonates with us in our experience at the Center for Healthy Aging is the peer-to-peer support and accountability and understanding of not feeling alone in the experience that can really help people to incorporate the positive behaviors over time in a consistent manner that can significantly impact their quality of life, which, as you showed in people, younger people with stroke is significantly impacted.
Yes, and the other thing I want to make a point for a new trainees, it's really, that's where the message can go really rapidly out. It's educating your patient, and then they educate their families. And I mean, but we have to prove that through science, really, for the providers to have a buy-in.
Yeah.
Yeah.
All right, well, maybe we'll give back the gift of time of a minute. And thank you
Yes.
again, Dr.
You're
Aleksandra,
welcome.
for your really outstanding talk. We're so
you.
grateful for your work, and hope everybody enjoys this sunny day in Seattle. Thank you again.
Have a great evening. Take care. Bye.
Okay, are we off?